Uses of airway ultrasound for difficult airway evaluation. A lot of these studies are in pilot mode, or people have just been kind of playing around. They don't really have the numbers. They don't really have the outcome studies to support it. But who knows what's going to happen in the next couple of years, especially with the evolution of the handheld and availability of ultrasound. But sublingual and transcutaneous approaches have both been used to visualize the upper airway. Hugh and Sue have done some work with sublingual transducers, and I'm not sure what transducers they used. Obviously, it's a special transducer to go into the oropharynx, but sublingual approaches uses a deeper probe, a little bit more depth than the typical linear probe. The epiglottis and laryngeal inlet are often poorly visualized due to acoustic shadowing. It's kind of tough to see the hyoid bone, but that would be a very good predictor of DL going from submental to hyoid bone. A more highly used approach is the transcutaneous approach, as you can see on the right here, using a transducer where you get some transcutaneous scanning done from the mentum all the way down to the suprasternal notch. What you see here is structures that are relevant to airway management can be examined by ultrasound, usually just using a standard scan, but in this case you can use a good scan to estimate tongue size. Airway-related structures that can be visualized by computed tomography can also reliably be identified by ultrasound. You typically can visualize the airway from mid-trachea with ultrasonography all the way to the tip of the chin, and some pretty easy to follow steps. Tracheal cartilage is seen in a longitudinal plane as a string of beads. That's longitudinal is also described as a sagittal plane. But you can see here in figure 1, you've got a string of beads here progressing from right to left, and it's seen as an inverted U in the transverse plane, as you can see here in figure 2. And then you have an air mucosal interface formed by reverberation, seen as artifacts on transverse and longitudinal planes. You can also see cartilage. Here is a nice view of the thyroid gland. You have a nice comet tail artifact here, just some reverberation very similar to what you see in pulmonary, which we'll talk about in a moment. Now this sagittal view here of tracheal cartilage we'll get into when we start talking about the cricoid and the thyroid cartilage, specifically as we talk about the cricothyroid membrane. And this is kind of an up-close view of what you get as you're scanning cranially. You can start down here around the sternal notch, and as you scan cranially, just before you get to the cricoid cartilage, you'll run across the, of course, here's trachea. Here you'll run across the tracheal cartilage, which is right here, along with the air mucosal interface. You see a little bit of the thyroid gland here as well. Those of you that are used to doing a lot of ultrasound for your line placement are probably pretty familiar with a lot of what we're going to see here, especially as we start to get a little bit more cranial, especially as we start to find the esophagus. The thyroid gland, as you go from sternal notch to the thyroid transversely, which is short axis if you're used to doing a lot of transthoracic echo. But as we move cranially, we see a series of tracheal rings. And what you typically see is you see when you get up to the thyroid gland, you see the isthmus of the thyroid, and you see both lateral components of the thyroid. It's a very important anatomical landmark and can be seen on either side of the trachea. Obviously, if you're wanting to do a tracheostomy, you're going to probably want to find the thyroid and delineate these structures before you start sticking needles in people. Both the lobes and the isthmus can be seen. It's a very nice, easy to find structure. If you're looking for the cricothyroid membrane, you often use the sagittal or longitudinal plane, as you can see here. Very easy to find. You typically find the string of pearls. Then you can easily find the cricoid membrane and the thyroid membrane, and the cricothyroid is a little structure in between. But in the longitudinal plane, the very hypoechoic appearance of the cricoid cartilage is seen as a bump or a hump here. Here it's outlined in red, but over here you can kind of see that it's very hypoechoic. The cricoid membrane is illustrated in green, the air mucosal interface in blue over here, and trying to give you a good idea about what the cricothyroid looks like in sagittal view. In the transverse plane, cricoid cartilage is seen as an oval hypoechoic structure here. There's the cricoid cartilage, and there's this air mucosal interface here just below it in some reverberation artifact. Tracheal cartilage in the transverse plane is viewed as an inverted U-shaped structure bordered posteriorly by a hyperechoic undeviating strip line, the air mucosal interface. In this particular view, we're looking at the cricoid cartilage, which is best seen as we move cranially. It's shown sonographically as a C-shaped mixed echoic structure, much thicker than the tracheal cartilages, with a similar hyperechoic strip line of air mucosal interface directly beneath it. The cricothyroid membrane should be seen a little bit further down, but you see this same comet tail strip here, which is very familiar, looks very much like the tracheal cartilage. The cricothyroid membrane is seen on the transverse view as a hyperechoic strip line sandwiched between the cricoid and the thyroid cartilage. And what you can kind of see here is you're starting to see a little bit of the thyroid cartilage right here. You see a little bit of a reverberation artifact here. Going from the sternal notch to the thyroid cartilage, you can see the thyroid cartilage is a nice big upside down V-shaped structure, and it has a trachea here. And typically when you get to the thyroid cartilage, you're going to start running across the vocal cords. If you're assessing the vocal cords are best seen using a transverse plane through the thyroid cartilage as a window. And here is this thyroid cartilage here, designated as TC. As well, you can start to see the cords here, the medial and the lateral cords. The arytenoid cartilage is down here. My scans never really looked this good, as you'll notice momentarily. This is during abduction, during phonation, and this is going to be during adduction or when you've got your cords closed. And the hyperechoic appearance of the vocal ligaments delineates the vocal cords, the vocal ligaments here and here. Transverse view of the vocal cords, you can see moving your probe up cranially. Here's your vocal membrane, vocal muscle, and I really did not get a very good look. I was saying a few words while I was talking here, but you see the thyroid cartilage here, and then vocal cords here, and there's here's a little bit of a arytenoid down here, and that's about the best I could do. If you're assessing for the esophagus, again, a previous picture had a nice picture of the double lumen endotracheal tube, which is there. It's not a double lumen tube, but that's kind of the appearance that it has. But typically you've got the thyroid and you've got an esophagus on the left side of the trachea. Here they've got the typical scan where the orientation marker's on the right, so your esophagus is over here. Here I switched it to the correct orientation. You have the thyroid gland over here, and you have the esophagus here, and you can see when I start to swallow, it kind of has a nice little jump to it. And then the trachea is here, and you got a little bit of a cricoid cartilage right up here between the tracheal and cricoid cartilage. Well, a couple of the really high utility uses for airway ultrasound is typically trying to assess the subglottic airway, especially in children. As you know, the glottic opening is not necessarily the most narrow portion of the child's airway. It is actually the subglottic region. And there was all the discussion and fight and everything about whether or not to be using an endotracheal tube cuff in children. Now we're all pretty much using it, but at least I guess it's a regional or a cultural decision. But here you are making a very nice little estimation of the child's tube size. Here you've got 0.62, which is the outside diameter of the endotracheal tube, which is, I don't know, probably a 4.5. But you can see here that you're measuring basically between the subglottic transverse diameter on either side and getting this nice little measurement here. You can do this with your butterfly. I've got an example in just a moment I use with my Sonosite. I've got no conflicts of interest, by the way. I don't work for Sonosite. It's just the device that I've got related to my practice. An interesting use for airway ultrasound, it comes when you're trying to evaluate recurrent laryngeal nerve damage, of course. And one of these uses is I typically go in a sagittal plane or longitudinal plane just to the left or right of the vocal cords, and you can see here I did a little check on my wife, and you see the letter E being said with her vocal cords, so obviously she's doing well with that. And I'm not sure if you can't get the same degree of utility out of just saying the letter E, but I think that you can actually discriminate between left or right recurrent laryngeal nerve damage with this technique. And here on this right panel, you can see where I actually measured the subglottic diameter and calculated an outer diameter on an endotracheal tube of 1.14 centimeters, which correlates with about an 8.5 endotracheal tube. My wife was very pleased to know that she could accommodate an 8.5 tube. Airway ultrasound can be used, as we spoke before, for ruling out recurrent laryngeal nerve damage. The incidence following thyroidectomy is about 1.4 to 5.1%. And you can see you can get a pretty good bit of movement here on this left side. Not a lot of movement over here on this right side. Usually it's noticed post-op, and monitoring techniques include NIMS tubes, fiber optic bronch post-op in some practices. Vocal cord ultrasound, again, is a viable option in assessing recurrent laryngeal nerve injury in about 90% of females, but in men it drops to about 50%. So it's not really something that you can hang your hat on. So this is a very good use of ultrasound. It's probably one of the top 1 or 2 utilities. And over here on the left panel, you can kind of see as you slide forward into sagittal view, you got your cricoid cartilage over here, thyroid cartilage that you can't really see too well, but you've got your cricothyroid membrane. You can see your cricoid cartilage in your CTM here. And then as you slide cranially, you can kind of see there's my cricoid cartilage over here, and I've actually taken a little bobby pin or a little paper clip, and I'm going to slide it up here and identify the cricothyroid membrane. And actually you can put a little Sharpie or something and mark it. You can also verify endotracheal tube intubation. Here the tracheal is visualized, and you can also notice the double track sign, which is demonstrating an endotracheal tube. You can also get the sagittal view over here in the right panel. So you get longitudinal and transverse planes, and the esophagus should be visualized as well. And if that's the case, then you're able to verify that it's not in the esophagus. And it's often complemented by a pulmonary scan demonstrating sliding. Some people like to use lung pulse, but sliding is so much quicker. And